name is Arun Singh. I'm a medical oncologist at UCLA. I focus on taking care of patients with sarcomas, and I'm part of the sarcoma tumor board at UCLA. So typically, a patient comes in to my clinic either has really advanced disease for which we use a few different types of standard treatments. Over the last few years, we've done mutation testing on these patients as well in an attempt to find new drugs to attack their tumors. Having the capacity to model their tumor in a mouse actually opens brand new avenues for us because we can test several drugs at a time. You know, when I get a next generation sequencing report, I can have 4 or 5 different options, but in reality, I don't really know which one of those options is the best for that individual patient. The real goal is to find these driver mutations. Taking the tumor, testing it in a mouse, growing it in a mouse, and testing these new drugs against it can help to identify the driver mutations and potentially a more effective treatment in a given patient. And at the same time, we can also avoid drugs that are not going to be effective in a patient, and also reducing the toxicity of those medicines. You know, this is not the first time people have tried to model tumors in mice, but a lot of times we found that the approach was started too late in the game, when patients' tumors were really advanced and their body was not able to take a systemic therapy. So for patients who it'd be a good tool to use, we try to use it a lot earlier on when we still have time to do different types of treatment for them. Yeah, I was certainly aware of PDX models, and they were always, I was not always quite sure that they were good models to use because most of them were subcutaneous, and you know, they had several shortcomings. For instance, they didn't always recapitulate what the tumor looked like in a human, and also they didn't have some of the other capabilities of tumors, for instance, to spread to other parts of the body. And so that was one of the shortcomings of that type of approach. And in many ways, this is the best mouse model that can be done for an individual patient, short of testing drugs in a patient themselves. I became an oncologist for several reasons. On a personal note, my grandmother died of breast cancer. And when I was young, I was always curious of what cancer was and the term cancer. And you know, when I was in college, I was still, you know, 18, 19 years old. And I still wasn't sure what a cancer was and what it meant. And even today, the definition is still being refined in my mind, what it is to mean to have a cancer. And so I've always been, in some way, very curious about carcinogenesis in general. When I was in college, I took a class in the molecular biology of cancer, and I was really fascinated by the process by which these diseases manifest. And lastly, I started doing research when I was an undergraduate as well. My boss helped to build mucin motifs, which are proteins that are used to stimulate an immune response in breast cancer. And so he synthesized these molecules and to try to develop an immune response against cancers. And so I was fascinated by, you know, so many different approaches to try to handle this difficult problem. And I was an engineer. I was a biomedical engineer, so I always liked to solve problems. And so in many ways, cancer was one of the ultimate problems to try to solve.